Hello and welcome to today's episode of Medisodes, where we'll be looking at public health. We'll be looking at the social determinants that affect public health, the rich history behind public health, examples of projects to help improve public health, as well as the ways in which the government has helped to improve public health in our society. But first, on to Adrian, who will be looking at how social determinants affect public health.
As defined by the World Health Organization, the social determinants of health are the non-medical factors that influence health outcomes. They are the conditions in which people are born, grow, work, love, and age, and the wider sets of forces and systems shaping the conditions of daily life. These forces and systems include economic policies and systems, development agendas, social stereotypes and policies, and political systems. In plainer terms, social determinants of health are factors unrelated to a person's biological well-being that affect the person's health and increase their risk of certain diseases. They focus on the interactions of social, economic, and political gradients in society that affect the likely health of a person. Oftentimes, it is not just a single of these social determinants of health that affects a single person, but rather a combination of several different factors from both the past and the present of the patient's life. Multiple mechanisms explain impacts of socioeconomic and other social factors on health. Especially with increased knowledge of biological mechanisms, it is easier to understand social impacts on health. Social determinants of health have an important influence on health inequities, which is the avoidable differences in health seen locally or internationally. These social determinants of health can be grouped into 5 categories or domains, namely economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. I shall now go through each of these 5 categories of social determinants of health in more detail. The first of these is economic stability. In the United States, 1 in 10 people live in poverty, where poverty here is defined as an individual with an income of less than $36 per day. And many of these people can't afford items such as healthy foods, good healthcare, and housing, which affects their health. They rely on unhealthier, cheaper foods, may avoid healthcare as much as possible, and may not have suitable living conditions for optimal health, such as central heating. Tied into this is employment status. People with steady employment are less likely to live with poverty and are more likely to be healthy. People with disabilities or conditions such as arthritis are limited in their ability to work, and so may find it harder to find a job, which then has a further negative effect on the person's health and well-being. Some objectives to improve economic stability include reducing the proportion of children or young adults who are not in school or working, increasing the proportion of children living with at least one parent who works full-time, and reducing the proportion of families that spend more than 30% of their income on adequate housing. Education access and quality is the second of the aforementioned 5 categories of social determinants of healthcare. People with higher levels of education are more likely to live longer and healthier, and so it is important to support everyone who needs such support. Children from low-income families and children with disabilities are more likely to struggle with basic skills such as reading and mathematics. They are, in turn, less likely to graduate from a university or college, and so are less likely to get safe, high-paying jobs, which increase their risk of health problems. Some objectives regarding education access and quality may include increasing the population of secondary school students who progress to graduate at university, increasing the population of children who are developmentally ready for school, and increasing the proportion of children with disabilities who are in education programs tailored for their needs. The next category, healthcare access and quality, seems the most obvious social determinant of health. It is a reasonable assumption to make that, given a person has restricted access to good healthcare, they will suffer from poorer health. Taxpayer funded, the NHS in the UK means that the effect personal financial stability and wealth is much less than the quality of care. However, in other countries where healthcare is not as freely available, money is arguably the most significant factor restricting people from accessing healthcare. There are also other factors that limit access to healthcare, including job commitments and hospital accessibility, for example, if you live in rural areas. This is because hospitals are more accessible in more urban places, where there are more people and therefore more patients. We next move on to the 4th category within the social determinants of health, neighborhood and built environment. The area that a person lives in has a significant impact on their health. Many people across the globe live in neighborhoods with high rates of violence, unsafe air or water, and other health and safety risks. In addition to this, some people are exposed to hazards at work that can harm their health, but this is out of their control because they rely on the job for money. Local and national policy changes can help counteract these health and safety hazards, and these may be funded by charities abroad as well. Local policy changes that promote the health and safety in the workplace include laws that impose certain safety standards in the workplace to ensure that hazards are kept to an absolute minimum. An example of an externally funded improvement in this sector is supplying areas where clean water is scarce with a pump and water filter. The fifth and final category of the social determinants of health is social and community context. This involves people's relationships and interactions with family, friends, and other members of their community. The people that a person is surrounded by may pose risks and challenges to people's health, and ultimately the aim is to make sure people are surrounded by others who do not provide them with any health and safety risks, which is linked to the neighborhood and built environment sector, as well as providing positive relationships at work and home to promote well-being. Some measures that can be put in place to improve this category are increasing the proportion of children who are read to when they are young to increase the relationship with their parents, as well as increasing the health literacy of the population, so more people are aware of potential illnesses and symptoms to allow for easy identification. These are the 5 broad topics of the social determinants of health. And now I shall hand over to Shrey to talk about the history of public health.
So the standard of public health within the UK has changed dramatically over the years. Let's start in the medieval period. There, waste was just dumped into the street and animals were slaughtered just in the road, not away from anyone. And this is obviously a great risk to public health. This poor public health led to the 1348 Black Death, which killed millions of people. It was spread by fleas, which were carried on rats that went through the city. Now, in 2021, many of us are quarantining, and the ship workers working in the 14th century would have been able to sympathize with us. Ships were quarantined for 40 days because they believed that the Black Death was being carried from abroad. Also, people who had the plague were quarantined, and a red cross was drawn on their door to make sure that people knew that they were infected and that they avoided them. Soldiers were sometimes used to guard the doors to make sure that people didn't go out of their houses. At this time, hospitals were mostly run by churches, as they were the only people with enough money. But the hospitals were only there for care, not cure. If you were too sick, you could be turned away from the hospital because the church didn't want the infectious disease spreading within the hospital. Now, public health throughout history has been tied to the scientific understanding of how diseases are spread. So in the medieval period, the works of Galen and Hippocrates, which are 2 ancient philosophers, were thought to be the main source of public health knowledge. And they believed in the theory of the 4 humours. And they believed that in the imbalance between yellow bile, black bile, phlegm, and blood caused disease. There was also belief in miasma, which is the theory that bad smells cause disease. Furthermore, at this time, the church was extremely influential, and they believed that disease was a punishment by God for those that have sinned, and that people should repent and they should go on pilgrimages and they should go to church in order to have their sins forgiven and the disease cured. At this time, the government, crucially, did not feel it was their responsibility for public health, especially due to the theory about health being down to morally corrupt people. Moving on to the Renaissance, and in Britain that would be when the Tudors and the Stuarts were running the country, you have the Great Plague of 1665. You may have learned about this in primary school history. And 100,000 people died in London alone. And they also used to draw red crosses, and they wrote, "Lord, have mercy on us." And this just shows how bad the plague was, and also beliefs about medicine. Such was the death toll that they buried people in mass burials called plague pits. The Great Fire of London of 1666 did help the situation, as it sterilized large parts of London, and also during its reconstruction, by such people such as Christopher Wren, London was built with wider streets and stone and brick buildings rather than the wood and mud that was there before. And this not only decreased the fire risk, but it also made the houses much nicer, and that contributed to better public health. Unfortunately, during this period, most government taxes was needed to pay for the army and wars, especially with France, because England loves to go to war with France. So there wasn't much money from government for public health protocols. Moving into the early modern period of the 17th century, the 18th century, we've got the development of the scientific method. Scientists were using dissections and microscopes to study the human body, and they found that many of Galen's theories that were treated as gospel were not true. And this is because Galen was not allowed to use human cadavers. He had to use other animals, which obviously have different anatomy, and that led him to false conclusions. At this time, smallpox was one of the most deadly diseases. And this leads us on to the story of Edward Jenner. So Edward Jenner was a country doctor, and he saw that milkmaids working in his village didn't get smallpox, although they did get a milder disease called cowpox. And he theorized that by giving a person cowpox, he could prevent them from getting smallpox later on, and this has drastically reduced deaths. So in 1796, he injected a young boy called James Phipps with cowpox. He then injected James with smallpox, and James didn't develop smallpox. So this led into the conclusion that this method of vaccination would work. Because he was a country doctor, many of the established doctors from the city disregarded his theory, especially as Edward Jenner couldn't explain why this was the case. However, as Anupam's going to talk about later, the smallpox vaccine had a huge impact on public health. Moving on to the 19th century and the Victorian era, we had greater understanding of what disease was caused by, and the crucial breakthrough was in 1857 by Louis Pasteur, who found his germ theory. And previously, they believed microbes were caused by disease rather than the other way around, and this is called spontaneous generation. Pasteur investigated the souring of sugar beet, which was used in the fermenting of alcohol, and he proved that germs in the air caused disease by sterilizing water, and he kept it in a swan neck flask that didn't allow airborne particles to enter, and the water remained sterile. However, when he kept the water in an open flask, microbes were bred on the surface. Furthermore, the German scientist Robert Koch linked specific diseases to specific microbes, such as the anthrax microbe, cholera, and for tuberculosis. And after this, there was a rivalry between Pasteur and Koch to develop as many vaccines as possible for these different diseases. And this is also fueled by the fact that France and Germany were at war at this point. There was also the development of the chicken cholera vaccine by Chamberlain, who was working with Pasteur on his vaccine. And Chamberlain forgot to inject the chickens with cholera before he went on holiday, and he left them out on his desk. And when he returned, he remembered and injected them with the cholera vaccine. And when he came back from holiday, he injected them with cholera. He then injected them with new germs to make sure that they were fresh, and the chicken survived. And this bit of chance led to the development of the chicken cholera vaccine. And this is because leaving the cholera out weakened it, which meant the effect was less. During the 19th century in the UK, there was the Industrial Revolution, and this led to cities such as Birmingham, Manchester becoming even more crowded. And at this time, the government had a laissez-faire attitude towards public health, which basically meant they said, leave it alone. That's what laissez-faire means. And they said that local councils were responsible for public health, and they left it to them. Then, Edwin Chadwick, who was working for the Poor Law Commission, wrote a report called The Report on the Sanitary Conditions of the Labouring Population. And this showed that poverty and ill health was caused by the terrible living conditions in industrial cities. And it wasn't due to idleness or moral bankruptcy like was thought before. And he suggested making sewers and having refuse removal. Unfortunately, this needed to be funded by taxes, and the people weren't willing to pay extra taxes for public health measures. However, in the 1848 and 1875 Public Health Acts, measures were brought in to improve public health. Cholera was also rampant during this period, and a man named John Snow mapped cholera during an outbreak in London, and he traced the source to a water pump on Broad Street. Legend has it that he removed the handle from the pump, and after that, cholera infections went down significantly. The 1858 Great Stink definitely led to the government rethinking their role within public health, as the River Thames became incredibly smelly due to hot summer, and this was felt in Parliament. They commissioned John Bazalgette to design the sewers for London, which are over 13,000 miles long in total. There was also the 1870 Education Act, which made education compulsory for children, and as we know, education is a key factor within public health. Going into the 20th century, the Liberal government turned its back on the laissez-faire approach and introduced more public health measures, such as old age pensions and sick pay. The Great Smog of 1952 also led to the development of the two Clean Air Acts to clean up London's air. But by far, the most important development in public health was the NHS. So during the war in 1942, William Beveridge, who was a civil servant, was commissioned to make a report on how to improve Britain after the war. And he came up with the introduction of the welfare state, which along with the NHS also came with the social security system. And in 1948, Aneurin Bevan opened the first NHS hospital, and since then, it hasn't looked back since. So hopefully you understand how public health has developed over the last 1,000 years. Now, Anupam is going to be talking about some of the most important projects in public health.
So Shreyas discussed how modern public health has come to be, but now we're going to talk about two specific examples of successful public health programs, one global and historical, and one national and contemporary. The first one I'm going to be talking about is a smallpox eradication program. Smallpox was an infectious disease caused by one of two viral variants, variola major and variola minor. And as of 1967, the ancient scourge threatened 60% of the world's population, killed every fourth victim, scarred or blinded most survivors, and eluded any form of treatment. However, by 1980, smallpox became one of two infectious diseases to have been completely eradicated by human effort, the other being rinderpest only 31 years later. All these eradication attempts around smallpox I will talk about are centered around using the smallpox vaccine that originates from Jenner's original vaccine, as was discussed by Shrey earlier. The first hemisphere-wide efforts to eradicate smallpox were made in 1950 by the Pan American Health Organization. This campaign was successful in eliminating smallpox from all countries of the Americas, except Argentina, Brazil, Colombia, and Ecuador. 8 years later, in 1958, Professor Viktor Zhdanov, Deputy Minister of Health for the USSR, called on the World Health Assembly to undertake a global initiative to eradicate smallpox, the first of its kind. This proposal, Resolution WHA A11.54, was accepted the next year. By this point, 2 million people were dying every year from smallpox. Overall, however, the progress towards eradication was disappointing, especially in Africa and the Indian subcontinent, places where smallpox was rife. By 1966, however, an international team, the Smallpox Eradication Unit, was formed under the leadership of an American, Donald Henderson. And then a year later, in 1967, the World Health Organization officially intensified the global smallpox eradication effort by contributing $2.4 million annually to the effort, and also adopted a new disease surveillance method promoted by Czech epidemiologist Karol Raska. In the early 1950s, around 50 million cases of smallpox occurred in the world each year. The new disease surveillance method, which I mentioned just now, focused on the idea of stopping outbreaks from spreading of smallpox by isolating cases and vaccinating everyone who lived close by. This process became known as ring vaccination. The key to this strategy was the monitoring of cases in communities, known as surveillance, and the containment of these cases to those communities themselves. The initial problem that a WHO team faced was inadequate reporting of smallpox cases, as many cases did not come to the attention of the authorities. The fact that humans are the only reservoir, however, for smallpox infection played a significant role in helping the eradication of smallpox. Over the years, the WHO established a network of consultants who assisted countries in setting up their surveillance systems and containment activities. Early on, donations of vaccine to help with these efforts were provided primarily by the Soviet Union and the United States, but by 1973, more than 80% of all vaccine was produced in developing countries where it was most needed. The last major European outbreak of smallpox came in 1972 in Yugoslavia, after a pilgrim from Kosovo returned from the Middle East, where he had contracted the virus. This epidemic infected 175 people and caused 35 deaths. However, authorities, now well practiced in dealing with these outbreaks, declared martial law immediately, enforced a hard quarantine, and undertook widespread revaccination of the local population, enlisting the help of the WHO in their efforts. With their help, in 2 months, this outbreak was over, showing the proof of Karol Rasker's new disease surveillance method being the most effective. Through the success of this global eradication program, smallpox was finally pushed back to the Horn of Africa and then finally to a single last natural case, occurring in Somalia in 1977. A year later, in 1978, a laboratory-acquired case occurred in the United Kingdom. Finally, the global eradication of smallpox was certified based on intense verification activities in countries and by a commission of eminent scientists in December 1979. The WHO finally endorsed that in 1980. The first two sentences of this resolution read, "Having considered the development and results of the global program on smallpox eradication initiated by the WHO in 1958 and intensified since 1967, declares solemnly that the world and its peoples have won freedom from smallpox." The cost of this eradication effort from 1967, when the WHO first intensified their efforts, to 1979, when the eradication was certified by a scientific commission, was roughly $300 million, a third coming from the developed world, which had largely eradicated the disease decades earlier. On the other hand, a much more recent example of a public health campaign is Change for Life, a public health program started by Public Health England, which began in January 2009. It is the country's first national social marketing campaign to tackle the causes of obesity. Social marketing campaigns such as Change for Life have the primary goal of achieving common good through using commercial marketing campaigns. This new methodology of public health awareness, combined with the relatively young target demographic of the campaign, led the government to use social marketing for this campaign. It adopted an integrated marketing approach and used a variety of marketing channels such as television, radio, digital, social media, public relations, and direct marketing. For example, animated television advertising by Aardman Animations, the team behind Wallace and Gromit and Shaun the Sheep, helped develop adverts for channels such as ITV, whereas international advertising agencies such as M&C Saatchi, who have worked with clients such as British Airways, led on the creative aspects of the campaign, with additional input from a range of other agencies providing PR, digital, planning, and data services. In total, the government's £275 million marketing push to tackle obesity saw supermarkets such as Tesco and Asda cut prices on healthy food, ITV launch a national health campaign, and companies such as Pepsi use their celebrity stars in fitness adverts on commercial television. The campaign also included £75 million of government marketing and a pledge of £200 million in services and ad space from a coalition of 33 companies, including Kellogg's, Asda, Tesco, and PepsiCo. In 2008, the then Health Secretary, Alan Johnson, said, "We are aiming to create a lifestyle revolution that will help families to eat well, move more, and live longer." The government declared at the time that more than 12,000 grassroots organisations, from the British Heart Foundation to the Fitness Industry Association, had signed up to the Change for Life initiative as of its launch, with more joining through the years. Change for Life began by encouraging families to adopt 7 healthy behaviours: 5 a day, recommending 5 portions of fruit and veg a day, 400, 600, 600, the recommended calorie intake at breakfast, lunch, and dinner, respectively, watch the salt, which was advice on reducing the amount of salt eaten each day, cut back the fat, which was an information campaign about the saturated fat found in foods, sugar swaps, which was information about sugar found in foods, 100-calorie snacks, 2 days a max, an information campaign to try and reduce the snacking that was rife in the country at the time, and get going every day, which was another information campaign about the importance of leading an active lifestyle. In its first year, Change for Life exceeded all of its targets by reaching 99% of targeted families, having 413,466 families join in the first 12 months, and over 44,000 families believed to still be involved after 6 months. The brand has thrived throughout the years in part because of its adaptability. What started as just a traditional campaign has kept pace with the changing ways in which families access health and support. As of 2021, they have a dedicated website, which more than 4 million families has used to register for support, one of the most used health apps in the country with more than 5 million downloads, a thriving Facebook community, and a YouTube page with 139,000 subscribers. Despite all this, however, its true effectiveness remains to be debated, as obesity rates in the UK have continued to rise, despite the widespread impact of this campaign and others like it. Next is Surya, who's going to discuss the role of governments in public health.
The government has been taking a laissez-faire approach for much of history, and public health is no exception. This means that the government didn't really get involved in improving public health and left it to individuals to realize that public health needs transforming. And we have already seen some examples of people who have helped revolutionize public health from Shrey's section. But it was only during the start of the early modern period that public health was influenced by government policy. For example, Edward Jenner introduced the smallpox vaccine through publishing his results in 1798. However, it was met with quite a lot of opposition from people who financially benefited from the inoculation methods used at the time, as well as those who had supernatural beliefs about being transformed into bovine creatures after being injected with Jenner's smallpox vaccine. Realizing the efficacy of the vaccines, the government made vaccines compulsory by 1853. This helped to suppress the spread of the smallpox vaccine and helped reduce deaths from smallpox. Before 1848, there was no official and formal state control of public health. There was no regulation of sanitation. However, in 1848, the first Public Health Act was passed. This Health Act did help to establish central boards of health who were responsible for drainage, water supplies, removal of nuisances, and paving. However, the lack of compulsory action limited the effectiveness of the Act. The continued prevalence of dangerous communicable diseases such as cholera and bad urban living standards urged the creation of the Public Health Act of 1872. It can be argued that the government's step to improve the Public Health Act was slightly political due to the Great Stink of 1858 affecting the living conditions of politicians and rich families, driving the need for improvement. The Public Health Act of 1872 helped to reduce the prevalence of cholera. Its increased effectiveness was due to many reasons. The Act established named local authorities as rural and urban sanitary authorities, replacing local boards of health. Authorities were obliged to provide clean water, dispose of all sewage and refuse, and ensure that only safe food was sold. It gave them the power to ensure that homes were connected to the main sewerage system. The local government board was given the power to make regulations to prevent the spread of diseases such as cholera. They also had the power to require 2 or more local authorities to work together to prevent or reduce epidemics. The stricter rules of regulation and compulsory action made this public health far more effective than previous public health acts. However, the most effective strategy that the government has carried out to improve public health is the introduction of the NHS in 1948. It was founded on the fundamental principle that healthcare would be free at the point of access, preventing social status from affecting health, which reduces the social gradients in health. It avoids income inequality from resulting in discrimination of access to healthcare services. Though the structure of the NHS has altered to favour private companies in recent years, giving firms more control over healthcare, the NHS is still one of the main reasons why the UK has a lower social gradient in health compared to the US, despite the fact that the US spends more on healthcare, suggesting the NHS to be a more efficient healthcare system. More recent government involvements in public health include the formation of Public Health England in 2013, Public Health England has a role of improving public health and reducing differences between the health of different groups by promoting healthy lifestyles, advising governments, and supporting action by local government, the NHS, and the public. Public Health England is also responsible for protecting the nation from public health hazards, preparing for and responding to public health emergencies, improving the health of the whole population by sharing our information and expertise, and identifying and preparing for future public health challenges. They also support local authorities and the NHS to plan and provide health and social care services such as immunization and screening programs, and to develop the public health system and its specialist workforce. They also research, collect, and analyze data to improve our understanding of public health challenges and come up with answers to public health problems. So this was just a brief overview of how government involvement has helped to improve public health over the years. Talking about public health, COVID-19 has been the biggest contemporary public health threat that we have faced. Check out the Medisodes COVID-19 playlist for more information on COVID-19. So thank you for watching this week's episode of Medisodes. Hopefully you have gained a good understanding of how public health has changed over time, the factors that affect public health, as well as an insight into the projects and government policies that have helped to enhance public health over the years. Remember to like and subscribe to Medisodes for weekly episodes.